Hello, everyone. So this is supposed to be the first trial for online teaching from my behalf. I hope this subject is relevant enough, so I thought it should be touching one of the major aspects about how we deliver care, especially with what's happening in the world right now. So I thought NIV should be, well, could be part of what we're interested in at the point. I have to say it's a bit tricky because NIV is a big it's a big subject, so you can either really get in depth and forget yourself there, or you can be so shallow. I hope I'm not either with this talk, but well, again, it's tricky. So what we're trying to get to discuss here is going to be different types and method of delivering in IV, non-invasive ventilation, and to understand what we're doing, we're going to discuss a bit of the basics of ventilation, and hopefully while we're at it, we're going to discuss what is good and what is not that good about each method. So, starting with the simplest question, what makes a ventilation non-invasive? Well, a common understanding is a ventilation that doesn't necessitate you to intubate the patient or to get past the vocal cords, which I think is practical wise, it seems like a good understanding of what non-invasive ventilation is. Although in practice, a patient with tracheostomy having CPAP or BiPAP is usually commonly treated as having non-invasive ventilation, which might be true in one sense, but actually it's not true from the physiologic point of view, because basically you had an invasive procedure to get a tracheostomy there. But basically what we're aiming to is deliver non-invasive ventilation with, hopefully a happy baby like that, or to keep them as happy as possible. So why do we where did the idea of non-invasive ventilation come from? Why has it become a bit more popular than back in the days? Well, first of all, it's easier. So you don't need to train a lot of staff to deliver non-invasive ventilation. Well, there is training, but it's not that much training in comparison to having to learn to intubate, for one instance. The other thing is it's got less complications because you don't have to get the patient to be basically in that state. You don't need to sedate them or paralyze them, and each drug will have its own side effect with the patients and its effect on hemodynamics. So it's a better situation with less complication in that case. It's cheaper because a lot of machinery that can deliver an IV are much cheaper. The programming is simpler in comparison to the different modes of invasive ventilation or conventional ventilation. So it's definitely cheaper from that perspective. And even though if you're going to deliver it with a ventilator, at least that means you've ventilated the patient with a ventilator, but still you can use the same ventilator to deliver the NIV. So it's still cheaper in that sense as well. Again, less sedation as a target itself is a target, because sedation, other than the hemodynamic instability factor that happens on the acute situation, it can also have more dire side effects on the long term, and it's also going to add to the time of hospital stay, basically. So again, NIV can add to the patient having shorter hospital stay, especially if they don't deteriorate getting to invasive ventilation or conventional ventilation. So if you're lucky and the patient just does well with non-invasive, then you manage to shorten their stay in comparison to conventional ventilation. And that's a good factor as well, especially with the for the last 2 decades, we managed to get a lot of patients with chronic problems like neuromuscular disease, chronic lung problems, chronic lung disease from the neonatal world, different types, even severe tracheomalacia, severe airway problems, to rehabilitate at home while they're on NIV until they get either their definitive treatment or, they get either recovery or basically withdrawal of care at some point. Depends on what their situation is. And the other aspect is sparing ICU beds, which is also a good point from the economic and management point of view, because you can spare the ICU beds for more dire situations rather than stack it with patients that could have done well with just simple ventilation support. So just to be able to go forward with the modules of ventilation, we need to maybe understand a bit about ventilation physiology. So if you look here, this is your tidal volume. So this is where your normal range of breathing and ventilation goes. So this is your normal breathing capacity when you're not thinking about breathing. That's your spontaneous breathing, basically. This is what it should be able to do, and that's called your tidal volume. And from that aspect, this is your target even with the ventilation usually, but it can go down, it can go up according to your lung status. But if you look here, your lung has got room for more because your total lung capacity is all of that. So what's happening here? Why are we just using that minimal part of our total lung capacity? Well, thinking about it, that should be enough, right? The tidal volume should be enough. That's the main cause here. But let's say you're in that situation where your brain needs more oxygen for some reason, like you've been running or you've been doing more exercise, or maybe even you're sleepy, so you're yawning. So you've got this room here, which is your inspiration reserve volume, and you can extend your inspirator capacity to get there actively and forcibly, and your lung can take that, but not for a long time, because you have to be actively doing that, and you can't just keep breathing actively all the time. From the other aspect, you've got room here, downstairs here for more, but why aren't you using that? Basically, this is what we call your functional residual capacity. So that should be left to keep the lung at a resting phase in a situation that can extend easily, to keep your tidal volume going with the minimal energy expenditure, minimal muscle use. So if your lung get down there, then theoretically they need more energy to get back to the tidal volume, because you're going to have to go all the way from here to there. So you can do that, but that's going to be forcibly, and that's going to be your using your expiratory residual volume and taking from your functional residual capacity. But that's as much as you can go. You can't get at this area here, because this area is your residual volume, that if you get there, if you collapse the lung further there, then you've definitely just collapsed the lung, and then to open it, you're gonna have to use a lot of energy and a lot of pressure to open it again. So this is where your body or your lung doesn't allow you to actively get beyond. But if your lung theoretically collapses because of a plug or something else, then you lose that, and then you'll have to go all the way from here to there theoretically to open up, which is not easy. So at that point, even with your tidal volume going all the way, like if you're just using the normal energy, you might be playing with the curves being down there, so you're just doing that. And excuse my roach drawing, but I'm just trying because I don't have other pointers on the mobile phone, so that's why I came up with that idea. But you get the idea, so that's how it is. So how do we breathe? We breathe basically by negative pressure rather than positive pressure. So our diaphragm moves down, our intercostal muscle expands, and that causes negative pressure in the lungs, and that draws air in. You can see the pressure on the left side hand. So it goes down, you're breathing air, and on the right hand side you've got your alveoli getting the oxygen in diffused to the vascular tree, and then you're getting the CO2 out through the main airways. Why is that important? Because basically ventilation is depending on positive pressure, while our physiology is depending on negative pressure. So this is the alveoli or the alveolus, theoretically, just thinking from the pressure point of view. So the equation now says the alveolar pressure basically is composed of mainly these four elements. So your your O2 pressure, your CO2 pressure, your water vapor pressure, and your nitrogen pressure, and that all should be coming from the air naturally. So there is room for the alveolus to expand until the pressure gets to the maximum point. But that maximum point can be just air, or it can be other stuff. And after that, whatever is getting more input there is going to affect the other components. So let's say you're dealing with a lung that is not being able to ventilate very well, or a part of the lung that is not ventilating very well. So ventilation means CO2 shifting, or ventilating shifting the CO2 out rather than the oxygen, mainly because basically the oxygen fraction in air is 21%. It's going to keep coming in as 21%, but it's all about the CO2 being flushed out, because that is coming from your lungs. So if someone has got respiratory failure type 2, they're going to keep accumulating the carbon dioxide. That happens usually in small airway disease. So in small airway disease, a patient is wheezy for some reason, or bronchiolitic or whatever, so they're not being able to ventilate very well. So they're keeping a bit of air trapped in, keeps being trapped until the movement is less than usual, the flow is less than usual. So the lung is trying to get CO2 out, but it can't. So CO2 starts to expand. It takes from the pressures from the other sides, because the alveolus can't really keep shifting air, so it's just being pushed through pressure. So CO2 pressure gets up. That means the FiO2 fraction is getting a bit lower, and then CO2 extends more. So basically, respiratory failure type 2 start with the CO2 accumulating, because at some point even the blood is not going to be able to shift a lot of CO2 out because of the pressure gradients, but also because with the and also at some point you're going to get hypoxic, which is the later phase of small airway disease. So if you've got an asthmatic child or a bronchiolitic child that is not managing to keep SATs up, that means they've been stacking CO2 for a while, to the point that their PO2 is a bit less than PO2 in the blood, and they can't shift it very well, and then, well, mathematically, they're not getting a lot of O2 going in. That doesn't mean that's always the case, because again, plugs can get lungs completely down, parts of the lungs completely down, but that's usually the main physiology. On the other hand, when talking about respiratory failure type 1, it's about oxygenation. So let's consider that red line going around the lung as a capillary or a blood vessel. So usually it's easy for the blood to get oxygen from the outer side and getting CO2 to the other side. So let's say for some reason you're not getting a lot of oxygen delivered to the blood, because maybe there's a bit of vascular constriction, a bit of VQ mismatch or something like that. So what you try to do is deliver more oxygen, and then by delivering more oxygen, you're able to get the PO2 a bit up, and the fraction a bit up, and that will mean that you can get O2 diffused to the blood vessels. But if you give more oxygen than needed, like if you keep giving a lot of flow with a lot of oxygen, getting the alveolar pressure a bit up, then you might risk that the bloodstream can't really shift CO2 out. So at some point you're going to compromise your ventilation while you're trying to oxygenate. And that gets us to the idea of VQ mismatch. So what is happening with VQ mismatch? Well, if you look at the middle, that's the normal stuff. You've got an alveolus covered with blood vessels in a good distribution. It's shifting air very well. So your normal VQ proportion is usually 0.8. But if you've got a pulmonary embolism with a patient or anything that is cutting the blood supply, like a congenital anomaly or pulmonary hypertension for some reason, or some shunting, blood is being shunted anywhere else, so a cardiac problem, you're having a VQ mismatch that is considered as indefinite because of the mathematical equation that we're not going to get to discuss now. But you get the idea. So the air is going in, but it's not having a lot of blood supply to meet. On the other hand, on the left side, if you look at the lung there, so it's been blocked by a plug, or it's been blocked by a collapse for some reason. Although the blood stream is really good going there, but you've got a perfused lung portion that is not ventilating well. So your VQ is about 0. So if that happens really quickly, then you're having hypoxia as well as you're having a problem with ventilation, because the lung needs time to redistribute the blood supply to the other areas that weren't having that much to basically rehabilitate with a VQ mismatch. So you've got a child with respiratory failure, either type 1 or type 2. So type 1 is considered as lung failure, although type 2 is considered as a pump failure. So pump failure, we're talking about the lung, we're not talking about the heart. So if you've got a child with central depression, mechanical defect as a plug, as I said, or small airway disease that's constricting some areas, or fatigue, then you're compromising their CO2 shifting. So what are you going to do next? Well, that's what we're about to discuss. You are going to ventilate. The first thought about what ventilation comes with is pressure, and the basic pressure with NIV is PEEP. So actually, if you look at the curve on the left side, it's a good curve to tell you about what is happening here. So this is a collapsed part of the lung, or alveolus, sorry for the lousy drawing. So this part needs pressure to come up to the normal bit. So you've got the pressure being really affecting the volume there. So you give pressure, but it's not opening the lung initially. And then you get to the inflection point where the opening of the lung gets really optimum with pressure. So whatever pressure you're giving is giving you better volumes. And then if you're giving too much pressure, you're compromising that the lungs are going to be over-distended. Why is over-distension bad? That's what we were discussing on the first, like 2 slides ago. So you start here with the lung being down, and basically this is your pressures down there. So a lung that is not well aerated is going to have decreased lung contribution and increased shunt, because now you're not using most of your lungs. So basically you've got like about 20% of it being down, and then you keep the pressures going up and you get to the inflection point and you get the optimum result. And then you give too much, so you collapse the blood vessels, you affect the alveolar pressure, and you affect the ability for the lung to shift gas, and then you add to the shunt again because of the over-distension, because it's basically an alveolus or a group of alveoli getting over-distended is going to compromise the capillary bed there being squashed, and also you're going to keep the pressure in the alveolus being so high for the pressure from the blood vessels gradient proportion, so they can't shift CO2 out and they can't shift PO2 in very well at that point. So you're compromising the alveoli, you're compromising the capillary bed by giving too much pressure, which is not good for your lung, and you're also compromising the alveoli lining cells health, basically. Okay, I hope that makes sense. It's really difficult to get what you guys think by now. I think it's too complicated for the moment, but let's get to the fun part. So what are the types that we're familiar with as NIV? So we're familiar with using low flows, high flow nasal cannula, CPAP and BiPAP. That's the common stuff, and that's what we're going to discuss quickly. So low flows. Well, low flows are our friendly stuff that we use everywhere, ED, ward, anywhere, you name it, you get it. So these are the most common used tools. So nasal cannula, rebreathing mask, facial masks, which is not rebreathing, and well, that slide, that picture had the tracheostomy opening as well. As I said, some people consider it non-invasive, but you can deliver low flow wherever, and according to the what you're using, you can titrate the flow. So with a rebreathing mask, you can go up to 15 liters per minute, but with a nasal cannula, depends on the caliber, but usually your maximum is 4 liters. The problem is low flows, not usually giving that much of PEEP, that much of pressure. It's just the patient's using their usual physiological capacity and their usual work of breathing, no matter what their work of breathing is. So basically, it might help with flushing air in and out with the flow, but it's not really adding much pressure support. So we don't really know what it's giving from that perspective, but we know it's giving a FiO2 if you're giving oxygen in it, which is usually why we're using it. But again, we don't really know how much of that fraction is being delivered to the patient. Why do we use it? It's really cheap. It's the cheapest NIV you can have. It's easy to apply. It's the basically. It's comfortable for the patient. It doesn't add to the anxiety. And as I said, increase oxygen tension, because basically if you're giving it, you're aiming to give oxygen, usually, except for neonates, to be honest. I forgot to mention that part, because neonates, if they're having like 2 liters per minute in a nasal cannula or 3 liters per minute, it might be giving them more pressure in comparison to their lung capacity if you're comparing that to a bigger child. There is a variable FiO2 delivery, which is on the disadvantage side, so we don't really know what's been delivered. It's not reliable for clearing CO2 because you don't know what's it adding to the ventilation. It doesn't add any mechanical support theoretically, so it's not adding any active pressure support to the lungs. It's not recruiting any part that is getting down if you've got a collapse or if you've got a consolidation. But that's all what we can say about it for the moment. But getting where the fun part starts, so high flow nasal cannula, which we are really good at using, I must say. So the most well-known manufacturers are Vapotherm and Optiflow, and down to the right side you've got the idea of how it works. So basically you need a humidifier, an oxygen source, a water source, and you just connect that to the patient with high flows. So high flows, we all use in pediatrics 2 liters per kilogram usually. Where does that number come from? Well, we've got good evidence that anything above 2 liters per kilogram doesn't really add much support. So that was where the evidence base came up as the inflection point as well. So we thought the research came up with the idea that anything above 2 liters actually doesn't have any significant value. So most of the practice stopped there. So the idea is it gives, why is high flow being useful? Well, it gives some PEEP, as you can see here, but where the PEEP lies from the lower inflection point, we don't really know. So it can be low, like really low, or it can be enough to support a bit, but we don't really know where it lies, which is the problem. It can be a PEEP of 2, a PEEP of 3, a PEEP of 4. We don't really know. All we know is that it's not that much to get to the distension side usually. So we know it's always around the lower inflection point or a bit far behind. The other physiological method about high flow nasal cannula is, well, we can explain with the drawing on the right side. So the flow is high enough to get some kind of a loop. So some of the air goes in with the flow, but some of it comes out from the oral cavity, which causes some kind of a stirring or a whirlpool. And because of that kind of movement and that kind of flow, the end result is that the dead space gets down. So the end result is that the child is actually breathing from the posterior part of their nasopharynx usually, or a bit lower than that as well. It depends on how big the child is and how old they are. So theoretically, you're washing out dead space. You're giving them less dead space to deal with, which will add to the support from the work of breathing point of view. Why it's good? As a high flow kind, why it's good? It's good because you can remember it by that kind of tricky use of the word high flow. So H is for heated and humid. So that should be helpful for the mucosal integrity, and that should be also helpful to liquefy some of the secretions. It adds support to the inspiratory demand. So because you're giving some pressure, you're supporting where your tidal volume is starting from. You're supporting where your lung is starting the inspiration from the pressure point of view. So it adds some support to the inspiratory demand. It decreases the functional residual capacity. Again, that's part of how it supports the inspiratory demands. It's lighter, so children will tolerate that better than CPAP or BiPAP. And I think we all have seen that. It dilutes, it minimizes the dilution of oxygen because of how the flow is going. So whatever you're giving as oxygen, you're mostly getting that fraction delivered to the patient in comparison to low flows. And again, as we said, it washes out dead space. It's cheap and it's easy to apply. And there's good evidence base supporting it as a tool with broncholytic children specifically, and with neonates. And there's also good evidence about it being a very good tool as a weaning step if you're getting down from ventilators. But we don't have enough evidence base to support with other diseases in other age groups. So that's one of the disadvantages, that it's not studied enough in older age groups. The other disadvantages are that it can't be used for recruitment reliably. So if you've got a collapse or part of the lung being down, and you know that, usually it's not your method that you're aiming for, because it's not reliable from the pressure point of view, and recruitment is depending on pressure. And the other downside is we don't have an established weaning plan that is unified or that is evidence-based. So different trusts, different units will have different practices. So you would be in one unit and you'll find them weaning off from 2 liters to 0. And you'll be in other unit where they're going to wean from 2 liters per kilogram to 1.5 liter per kilogram, and then to 1 liter per kilogram, and then they take it off. And you'll be in another unit where they're going to have other sense of weaning, like maybe a liter every 2 hours or something like that. So it depends on units, but we don't have a unified practice for it or evidence base behind our weaning plans. But it's a good tool, mainly in the small infants. That takes us up to CPAP. So CPAP I think is mostly well understood in comparison to a lot of other methods, because we've just discussed PEEP. So CPAP is basically a tool of delivering PEEP reliably, knowing where we're giving it. And so you're aiming to get to the lower inflection point to support your tidal volume, keep your functional residual capacity being up, which is your main target. And the best thing about it is you can keep titrating the PEEP to get there, following your blood gas, following your SAS, following your CO2, and you would be a bit able to know where you are. So if you look on the upper right zone, it gives you a very good picture from CT point of view about a lung that was, or both lungs were down, and then you're giving PEEP, and you can see with the lower inflection point how that is affecting the lungs. So basically getting them a bit in the where they should be here, and mostly like there, and then at some point you extend that more than you need to, and there's a bit of emphysema. So this is not the best pressure up there, but I think it gives a picture about how pressure affects your lung extension. And that's how we're targeting things with, oh, excuse me, sorry, being a bit confused, sorry. Okay, and that's how PEEPs and CPAP should be working. So as we said, if you keep your functional residual capacity being up, you're decreasing the shunt and you're getting your PO2 up. And also if you're improving your compliance, you're getting your work of breathing down and you're adding to your ventilation. Here you can see these two lungs are having PEEP of about 10, which seems like it's not enough for them. Sorry, that was 8, which was not enough for them. That's, well, the picture comes from adults, to be honest. And then they had a PEEP of 10, and the lungs seemed good enough. So it seems like PEEP of 10 here was the target. We didn't need anything more. But if you keep recruiting with more PEEP, then actually you're causing more harm because the lungs here are over distended. And that has got negative effects, and we're going to explain why. But mainly our advantages with CPAP are that setting the PEEP helps with reliable recruitment because you know where you're going and you can titrate that. It improves compliance and it improves the VQ mismatch by keeping the functional residual capacity being up. It prevents further atelectasis because you can take the pressure gradually down rather than unreliably. So if you're comparing to high flow, I think high flow is good with increasing the functional residual capacity, but you can't titrate that. It also gets a bit of compliance. But the best thing about PEEP in that comparison is you know where you're going. It can be delivered by different modalities and different machines more than any other module because it's been well studied for ages, and it's the basic mode for all of the ventilators in the world. So you've got CPAP in every kind of ventilator that I know of, at least. So these are the advantages. But the disadvantage on the other side is too much PEEP is not advised, can worsen ventilation. So that lies in your hand. You can titrate that. It's not really a disadvantage of CPAP as itself. Again, too much PEEP can compromise the hemodynamic stability as well. We're going to explain why. It's not well tolerated by pediatric patients in comparison to high flow. It needs a good seal to be delivered well, so it's really tight on the face or the nose, and it causes a lot of fuss by babies, which might compromise ventilation if they're not coping or tolerating it well. It can compromise feeding in little children due to overdistension. So yeah, you can appreciate the distension there in the picture. Again, I just wanted you to remember that we're usually breathing with negative pressures being applied, and you've got the curve from the PEEP point of view. But why is that important, and why did I mention that too much PEEP can compromise your hemodynamic stability? If you look on the upper left side with that animation there, it's this is how we usually breathe. So if you look at the curves, so with inspiration we've got negative pressure, which it helps the venous return come from the IVC to come up, and so basically it's sucking blood as well as it's sucking air, and the blood comes from the IVC and the SVC and gets to the right atrium while we're breathing in more than it's coming while we're exhaling, basically. So if you think that we're inverting the equation here, giving PEEP, giving pressure, so we're adding to the intrathoracic pressure, how do you think that's going to affect our venous return? So basically, giving a lot of PEEP is abolishing the negative pressure equation to suck blood from the IVC and SVC to the right atrium. And that's how you might compromise the hemodynamic stability, by giving too much positive pressure to the lungs. So it's all about balance, really. So if you look on the right side, balancing ventilation priorities is where you should be aiming. If you give too low PEEP, and when I say too low PEEP, it's relevant to the patient, not as an absolute number, you compromise the atelectasis being still a problem if the lung had some collapse, and you're compromising the hypoxemia and hypercapnia being building up. If you give too much PEEP on the other side, you're adding to the VQ mismatch. And I said, I did explain that initially, and you're causing some alveolar capillary injury. You're adding to the inflammation process, and you're adding to the intrathoracic pressure, and part of the intrathoracic pressure that is you're adding to the pulmonary hypertension. So it's a lot of problems if you give too much PEEP. So how do some people come over that? So if you've got a patient with a derecruited lung or collapsed lung, and you've given PEEP all the way up to, let's say, 9 or 10, and you're worried that you can't go further, so how did people try to overcome that without giving too much PEEP? Well, basically, there comes BiPAP. So BiPAP is basically PEEP with intermittent positive pressure inspirations. So you can give whatever you can give as an upper pressure breath. So you keep giving breath with pressure that is more than the PEEP, giving some delta P to open up the lungs and to add to the mean airway pressure. So if you think about it from the physiology point of view or from the physics point of view, if you're giving that much here, well, you're giving some pressure, but eventually you're dealing with the mean pressure covering all of that area here, which might help your tidal volume being a bit in the right position. So you add more here and your mean airway pressure is going to be more. And by having mean airway pressure being up without consistently not allowing the venous return, not allowing the lungs to recoil, rephrasing, if you give better mean airway pressure with allowing the lungs to recoil, allowing the venous return to come back, then you kind of had the better of both. But it's not always that easy to achieve or what you're targeting for. So this is something I think where we might benefit from, is understanding how BiPAP can be used in two different ways. You can give BiPAP to recruit the lungs in a patient that is breathing and having regular breathing with work of breathing, of course, by increasing the inspiratory time, because basically when you're giving the upper pressure or the Pmax, the patient can breathe over it. So it's not like you're stopping the patient from breathing completely, but it's just the problem is you're adding too much pressure. So the trick is giving some more inspiratory time, but still being able to get the lungs some kind of rest. So if you look here, this is usually used to really increase the mean airway pressure, but with giving the lungs some time to recoil. So this is where the patient's breathing was. This is with PEEP, but this is with the BiPAP support. So you can imagine how is the impact is coming up from that. It's like giving some time for the collapse to open up by giving a longer breath, a longer period of pressure, but allowing the lung to breathe around that pressure. But if you're using BiPAP to support the respiratory drive in a patient that is being tired, or a patient that has got weak respiratory drive, maybe because they're a bit sedated, a bit drowsy, or has got some kind of disease that is not allowing the respiratory center to react. So this is the method that we should be using, which is basically just like mechanical ventilation, but in IV. So appropriate inspiratory time, allowing just for breathing time, mimicking the normal, but with better pressures. So from that perspective, the advantages of BiPAP are either supporting inadequate respiratory drive or increasing MAP, but giving some time for venous return and giving some time for the lungs to recoil and exhale properly. It's a last resort before intubation, and it can be used, and it's usually actually used with patients with neuromuscular disease or nocturnal hyperventilation at home. So it allowed a lot of patients to go home, to be honest. The disadvantage is the least tolerable in IV because of the pressure being applied on either face mask or a nasal mask with a child with different pressure gradients. It's not really pleasant. More difficult to keep on patients and demands a lot of attention because any leak means you're not really achieving what you want, and it's really well known to have a lot of leaks from the masks or the nasal pieces because children don't tolerate it, so it's like a compound problem. It adds more to the gastric distension apparently, which leads to a possibility of aspiration because you're over distending the lung massively in short time. So actually if I'm getting to give you like a main message here, it's all about aiming your pressure targets. What are you aiming for? What are you trying to achieve? So on the left side, if you're aiming for just low pressures, like what you can achieve with the high flow nasal cannula, then the advantages you're achieving is you can use it as a weaning method. You can maintain some lung volume in premature babies or little infants. Still can be used in bronchiolitis, although because still a good way to get the benefits without annoying the child that much. Adverse effects on the other side is just it might be too low to give you the adequate volume if you've got a de-recruited lung. And then if that is the case, then you're not really adding to the ventilation. Aiming your pressures to, well, a medium zone like 4 to 7, well, hopefully that will help you to recruit the lungs, especially with restrictive lung disease. And then if you achieve that, you can stabilize the lung and improve your VQ mismatch. But the adverse effects are you can distend the lungs massively if you're not paying attention to the pressures and distend the abdomen. If you're aiming too high, that might be a target at some point, giving you the advantage to recruit the lungs, especially when you're not really winning. In that case, you can get that and then go back to the medium pressures, but just achieve your target basically, because the adverse events are higher possibility for air leaks. You can impede the venous return, as I said, and you can add to the CO2 retention because the pressure in the alveoli would not allow the lungs to exhale or shift CO2 out. And if you're interested, that was just a study that I was part of back in CATS, to be honest, where we were assessing the safety of NIV in transport of critical ill children. And I think although the study group was not that big, but I think it did show that a lot of them didn't need intubation on the way or even after getting to the PICU. So just 2 of them had intubation within an hour, and these were the ones that were not that suitable, I would say, out of 200 patients. So that was a good sample, I would say. Thank you very much. I hope this session is a bit useful. It was a bit of a first experience for me to do it, well, just from my side. So I would appreciate any feedback. Thank you very much.